You may go ahead and ask and say, oh, well, what are you doing teaching a course or talking about code blues and nursing implications? But one of the things about me is I started off my career at the age of 18 working at a quaternary level 1 trauma center as a clinical assistant in the emergency department, where I felt like it really helped propel me in my profession in the work that I did. And I was always really involved in the emergency medical services field, working and rising in the ranks in EMS, working as an advanced life support provider, where I really fell in love with resuscitation. And it's really funny, I still have a book bag from one of my first mentors who said that it says, I don't want you to get hurt, I just want to be there when you do. And so that has always just been my passion. As I went through my career, I was a nurse educator, and then I ultimately became a critical care nurse practitioner, where I still practice on the weekends when I'm available, and not wanting to feel like I really need the day to rest. But I still work in a community hospital in an ICU as a critical care NP. But in my previous role, I built a team that worked together of critical care nurse practitioners who now we went from myself of 1, and now the team is 6 strong and almost 24-hour coverage to really talk about how do we mitigate emergency responses? How do we stay away from code blue, right? How do we keep from that? So whenever I think about resuscitation, I always like to remind everyone to take a breath, that this is what you're made for and this is what we do. How many of you guys have participated in a resuscitation before? Great. Can you tell me a little bit about what that experience was like for you? Sorry? Tiring. Okay, what made it tiring? Okay, so it's work, right? We have to do the compressions and all of those things. Anything else? What about the environment? It's chaotic, okay. What do you think led to the chaos? I'm sorry? You can speak up, it's a safe learning environment.
If the roles are not, everybody's doing the same thing and not a role is not assigned.
Excellent. Yeah, right. If I were to go ahead and call a code blue, I would expect that there's going to be like 40 people running into the room going, what's going on? And then really, if we're not defining those things, it can lead to a lot of different things, right? How about anxious, right? Especially like if it's your patient and you're like, oh my God, right? I see a nursing student here. Not to point you out, you're like, great, I'm the only one who showed up today for the pizza, right? But think about your very first day. If you're going to go ahead and take care of a patient, what are going to be some of your thoughts if your patient starts to decompensate? You might be like, oh my God, what did I do? What was the last medication I gave? Oh my God, you may even not even think about those things. You just may be like, oh my God, what is happening right now, right? So always remembering to take a breath. This is what you're made for, and this is what we do. I will go ahead and say, and I've said this often and people will look at me like I'm crazy, I personally don't believe that there's an emergency in the hospital, okay? Why? Because we are all trained to be able to take care of our patients. The other thing I like to remind, especially my new nurses, is that at the end of the day, do you really want the nurse who's caring for that patient or the doctor who's caring for the patient or the nurse practitioner to be like, oh my God, what's going on, right? And one of the things, that, especially when I used to respond to resuscitations, they would always say, Andrew, you're so calm in this. How do you stay calm in this? And I'm like, to be honest, I was kind of shaking in my pants. Sorry, I know this is being recorded, right? But I had to stay calm, right? Because that's how I would be able to lead my team. That's how I would be able to go ahead and figure out what I need to take care of my patient. So always remember to take a breath. This is what you're made for, and this is what we do. But we know that we have a lot of different challenges, right? And so whenever I think about resuscitation, I love this picture over here. I always said the best places for me to do resuscitation was either in the back of the ambulance. Why? Because it was just me and my partner and I can do whatever I wanted and nobody was telling me what was going on. And then when I look at this picture, I think about, well, everyone has a role, right? Everyone's kind of assigned doing their thing. When I worked in the emergency department, it was really great because, you know, it was my friend who I would maybe go grab drinks with after a night. But when I was an educator, I remember when I first started as an emergency department educator, I was handed a beeper. And they're like, this is the code beeper. And it's part of your responsibility that you respond to codes as well. And I was like, okay, great. And so I would go up to the floors, and this is what I saw, right? And is that the truth? If I were to call a code blue right now, what would happen? You'd have probably 1 million people come show up, right? Some of them are like, what's going on? What's happening in Rust Auditorium? Is there even a code cart in Rust Auditorium? Right, but there is. But a lot of different things. And what are some of those things that we see in the inpatient side? Well, number one, there's too many bodies, right? We're in an academic teaching facility and there's a lot of people. And sometimes there are people there who are just there to learn and be the fly on the wall. But also there are people who are really there, really willing to try to help. Limited space, right? Depending on the area that you work in, right? Some units have 4-bedded rooms. And we don't have a lot of space, right? There could be family members in there. There can be equipment like, you know, bedside tables, or there could be other different types of recliners. Lack of role delineation, and you talked about that, right? Why is that? And one of the things that I remember was that we would always say, and I teach this to nurses, I teach this to nurse practitioners, I teach this to resident house staff members, I teach this to doctors, and when I talk to them about this, I say, often what happens is that we have role confusion more than figuring out role delineation, right? Really trying to identify these different things, because one of the other factors is battle of services. And I always found that really hard, right? Because if you're on 9 Monty and you're taking care of a surgical patient and a medical team is coming to you, right? Or maybe Amanda's responding to your unit, you may not know who Amanda is. And now you have to figure out, how do I work with this team, right? Who I don't know, right? And trying to go ahead and care for this patient in the most critical times. Technical skills is another component of that. So I always like to ask people, how do we get back to this picture, right? And the way that we get back to this picture is that we train like you fight. This is something that we talked about all the time in EMS. Why do you guys have amazing nurse educators here? Because they're here all the time, getting you ready so that if there is an emergency situation, or maybe it's the first time you're doing a skill, that you're there ready to go, right? Develop competency and roles in all team members. And when we talk about this, Amanda's going to talk a little bit about what the different roles are. Why is it so important for everyone to know the role? Why? Because you should be able to really go ahead in an emergency situation. I always say one of the best things about an emergency situation is when you walk into it, figure out where you fit. Right? I'm a big guy, and I'll tell you that's one of the things is that I don't need to go there. I can go ahead and run the resuscitation. I can go there and think about, okay, well, maybe I'll just be the person putting in the IV. Maybe I'm going to be the person who's looking through the code cart. Maybe I'm the person who has to run to the blood bank to go get blood because we're talking about a mass transfusion right now. But being able to get everyone ready to understand, assess what's the situation, and think critically to get through the situations. Debriefing. Those who have participated in resuscitations, how many of you debrief? Great, not as many hands as those who didn't, right? Everyone deserves a debrief, okay? Why is it important to debrief? Good, so maybe talk about what could have gone better, or how about what went really well, right? What went well? Or the other thing is to go ahead and make sure you have that closure. Right? And it's supposed to be a safe space, right? All too often, we know, I can tell you, some of you guys didn't raise your hands, you do debrief. But where do you debrief? You debrief in the break room. Can you believe Andrew said that to me in the middle of that resuscitation, right? But me being the person who may have been leading the code, I may not have known that I meant something like that, or that that person received something like that. Does that make sense? Right, so debriefing is really important. I always advocate to tell everyone, if your teams are not debriefing, ask for a debrief, because everyone deserves a debrief. And it's really important, especially sometimes, you know, when we're working in stressful situations, depending on where you work, you shouldn't be expected to go back and do what you need to do, but we have to, right? But you have to go ahead and figure out, how is it that maybe it is the first time you've ever been in a code, or maybe you felt like it was a really traumatic situation. Always having a plan. This is something that's so important, right? So when you guys think about this, all too often I see this on the medical surgical floors where, Hey, I call a code blue in room 301. I'm just making up a room, right? 301. Well, guess what? There's 40 other patients on that floor, and everyone's in that room. Who's watching the other patients, right? So always having a plan, thinking about those things. I think in the critical care areas, we do this best, right? Who's going to go grab the code cart? What would happen if this? Who's going to stay in charge? Looking at all of those things and having that support. And really standardizing response. And this is something I think larger that we have to work a lot on in the hospital realm of trying to standardize who responds, what's going on. One thing I did notice here, I believe for most of the rapid responses, they are silent pages, which I'm a fan of. Why? Because there should be an escalation pathway. And I'm going to tell you in some of the other places where I've done some of this work, I advocated for that because I'm like, why do I need 40 people in the room? Let's get the people who need to be there. And then if they're not there, then let's go ahead and escalate it and make it a live page. So there are some things that work out with that. So I'm going to ask you, crap, your patient's looking like crap. What's some of the first things that you're going to do? So you're taking care of a patient, the one in the blue sweater. What are you going to do if your patient's Awesome. Great. I'm going to tell you that they're unresponsive and you don't think that the patient has a pulse.
So I'm going to call for help.
Great.
Get the bed flat and start.
Awesome. That's something that I always bring up to people, right? Go back to your basic life support, right? Hey, are you okay? No response. Okay, checking for a pulse no longer than 2 seconds, right? Remembering some of those things. And then saying, I don't want to do this by myself. I need help. What do I need? I need help. I'm going to call a code blue, whatever you need to activate the emergency response system. I need to go ahead and get a code cart and I need a defibrillator, right? One thing I'm going to tell you today, for anyone who doesn't work in an ICU, because I feel like my ICU people should know this, but if you don't know it, you should do it as well. If you ever have an emergency response, the things of your priority actions are going to be calling for help, okay? I'm going to tell you every single, when I used to do EMS and I used to teach my medics and people who are working on the ambulance, I used to always say the middle thing before you show up to the hospital, O2, IV, monitor, finger stick. Okay, why? O2 fills that airway breathing circulation, right? Going ahead and let's give them some oxygen. Sometimes, especially if they're freaking out, it allows you to give them some happy juice. It makes you feel like they're doing something for them, all right? IV access is important. Why? Because you need to be able to give drugs or anything like that. Monitor. You don't know what's going on with your patient unless you go ahead and have this patient on the monitor. All too often during a resuscitation, I'll get to a resuscitation, I see there are multiple Dynamaps. There is a manual blood pressure cuff. You don't need any of that. You just need the Zoll. The Zoll does everything. It has a blood pressure, it has EKG, it has pulse ox, and all of those good things. And then finger stick. I used to say when I did EMS, my favorite thing was to work in Times Square because I would always look like a hero when the 16-year-old girl who's visiting New York City, hasn't eaten anything all day, is unresponsive on the ground. I put an IV in, give them ambidextrose, and all of a sudden they're magically awake, and mom and dad are like, "Oh my God, you saved my daughter!" It's like, so finger stick, right? Because mental status can be changed really quickly. Those are things that hypoglycemia is really easily treated. So during your emergency responses, right, I always think about, when I think about what do nurses do in an emergency response and what are nurses' roles in all of this, right, I always think about this movie. As nurses, we're everything, everywhere. What is it? Everything, everywhere, all at once, right? And so that's the truth, right? Because at the end of the day, that's what we're expected to do, right? Be everywhere, do everything, all at the same time, especially in emergency response. And so when you think about that, again, this is what we're made for. This is what we do. So always remembering your basics. We talked about calling for help. Airway. Don't forget your basic airway support, right? Going ahead and just giving them oxygen, maybe an ambu bag. I always like when I teach this to PCAs and I say airway, and they're like, the head tilt, chin lift. I'm like, you guys all learned BLS, or you learned heart saver, right? Or when I teach this to nurses, same thing. It's like, oh, we didn't know that we could do that. Yeah, that's what you should be thinking about. We're not telling you to intubate the patient, right? But breathing, looking at the patient's breathing, assessing what's going on. Are they breathing normally? Are they breathing really shallowly? Circulation, what's their skin color, temperature, and condition? Do we have good access? And if not, what do we need to get that access? And we'll talk a little bit more about that. Other things, whenever I talk to people, and this is for like my critical care nurses, when you guys are going to rapid responses, think about why the patient's admitted to the hospital. I can tell you the number of times I've responded to codes, and I'll get there, and the code's been, one time there was one of the house staff members had come down to the ED because they were getting an IO. And I was like, okay, what's going on? They're like, I have an inpatient code. And they're like, but I don't know how to use this. I was just told to get the IO. And I was like, okay, cool, I'll go with you and I'll show you how it's done. And so I go up there and there's 40 people in the room. And my first question was, okay, so we're gonna put the IO in, but like, why is the patient here? Oh, he came in because he came in for hyperkalemia 2 days ago. Did we treat the hyperkalemia? No. The patient's been resuscitated, active resuscitation for almost half an hour before they went to go get the IO. That's another talking point. But so think about, why is the patient here? If I hear a code blue in maternal child health, I think I had to cover Marianne one time when I first started here, and I heard a code blue and I was going there. Someone is hemorrhaging. That is what my thought process is, right? Because of where the patient's located. Luckily, I found out that it was just like a father who liked syncopation. So what is the most likely cause of the patient's deterioration? And then what are the patient's goals of care? This is something that I think COVID taught us a lot better. We were really sucky at having these conversations, and some of us were still really sucky at having these conversations, but understanding what is it that the patient would want, right? I always like to say to my patients, do you want me to do chest compressions on you? No, I'm just kidding. But like, those are some things that you want to think about. Having those conversations is really important. I'm going to hand it over to Amanda, who's going to talk a little about role delineation.
Right. So to introduce myself again, I'm Amanda Biancardi. I am a MICU nurse. I've been working there for a little over 6 years, so I've had the opportunity to participate as the RT nurse multiple times. I've been to some wonderful rapid responses where everything's kind of tied up with a bow, everything goes smoothly, and you walk out of there feeling great. And I've also been to plenty where it's just chaotic and craziness. But one thing that I've definitely taken out of it is it's always run the best when the roles are assigned properly right from the get-go. So as you can see, we have our perfect little graphic of ideally in either a cardiac arrest or rapid response where each of these roles would be located around the patient, who's filling those roles. And I'm going to go into like a little bit of what each of those roles expectations are. So first is the team leader. Most of the time when we're responding to rapid responses, it's the MAR, medical admitting resident, who is running the rapid response and should be identifying themselves and introducing themselves as soon as they walk into the room as the team leader. Usually the first thing you'll hear when they walk into the room is, why is the rapid response called? And that's a lot of the time how you can identify who that person is. Usually they're coming along with a team of other medical professionals, whether it's NPs, their residents. I think something I'll probably emphasize multiple times throughout all of these roles is communication, but definitely with the team leader is kind of the number one priority. The team leader is responsible for communication to and from the rest of the team, communicating with the recorder, making sure that everything that they're ordering is being written down, communicating with the nurses and the providers, making sure the interventions are being completed, communicating with the secondary provider who might be able to give information to them about the patient to kind of get a better picture of what's going on. This person should be the person assigning the roles. So for example, in a cardiac arrest, oftentimes in a perfect world, you'll hear the team leader say, okay, Nurse Amanda, I want you on compressions. Nurse Andrew, I want you on the code cart. NP, I want you pushing meds, and you have those roles laid out from the beginning. Of course, it doesn't always work out that way, but ideally, this would be the person assigning those roles. Overall, this person's going to be directing all the orders and interventions based on the information about the patient that they receive. Sometimes it could be their first time laying eyes on this patient, so keeping their ears open for information and assessment information from the nurses and the providers as everything's going on. And then ultimately, this person will decide the patient's overall disposition, where they're going to end up, if they're going to be transferred to another unit, if we're going to continue a code, if we're going to end a code. If there's conversations with the family, this is that person.
One thing to bring up about that, so really great job. I think whenever you think about team leaders, it's really important to, one of the things I learned in EMS was that how do you tell the difference between a chief and a frontline team member? Does anyone know? Let's say there's a house fire. How do you tell the difference between a firefighter and a chief? The chief's outside. I love that. The chief has the whitest coat. All right. And I'm going to tell you why that's important, because one of the things is that if you are too involved as the person who is the team leader, you're not the person overseeing the entire resuscitation. And I've seen a lot of errors that have happened there. I'll give you an example. I went to a resuscitation one time where my pulmonary critical care fellow was the team leader, but then they identified or were concerned for a pneumothorax, was setting up for putting in a chest tube. And the feedback was what happened afterwards? We weren't giving meds anymore. We weren't doing other stuff because the chief was no longer being the chief. And so being mindful of that is really important.
And ensuring that ACLS algorithm is used as well. That should be that person making sure that every step is followed. Like I said, they're usually escorted with a team of providers that are in the room as well. The support provider can be an MD, NPPA. A lot of times these are the more hands-on provider in the room. So for example, often when a code stroke is called from a rapid response, I'll see that this secondary provider doing the detailed neurologic assessment, maybe while the team leader is getting information about the patient's background and history from the nurse, or from results and things like that. So definitely you'll notice this person doing assessment. This person should also be comfortable with that ACLS algorithm and flow to make sure that the team leader is following that appropriately, making suggestions based on their assessment feedback. And a lot of times also you'll see this provider in the room with the WOW, and they're entering orders, which is super important because we don't want there to be any delay. A lot of times orders are being shouted, but maybe not placed into the computer, and the rapid response nurse may be drawing an ABG that's supposed to be sent stat, but we have no order. It gets down to the lab, there's no order. So this person's job is definitely to ensure that all the orders are entered as quickly as they can be so that there's no delay in care. Things like MTPs and getting blood transfusions, you want to make sure that that's happening without the delay that Sunrise unfortunately sometimes requires from us. Primary RN, so this would be the nurse that is assigned to the patient, or the nurse maybe who witnesses this event, who sees the patient start to decompensate and realizes that they need to escalate and need help. The most important thing for this nurse is, as we've already kind of talked about, staying at the bedside. You don't want to be running into the hallway and leaving the patient looking for help. You should be pushing your code blue button, screaming at the top of your lungs if you need to, and making sure that the ABCs are addressed for that patient, whether that's the ambu bag, whether that's starting compressions. And that way, when the team arrives, you are the one who knows the patient the best, and you can provide all the information that's needed to kind of figure out why this event has occurred in the first place. Of course, again, communication with the team leader, that SBAR format, but based on experience, the two terms that I feel are most important are last known normal. You'll hear that a lot. You're the person most likely who last saw the patient when they were at their baseline. And then baseline, that term as well. What is their baseline mental status? Is it different from what's going on now? What are their baseline vitals? Are they actually hypotensive, or is their baseline systolic blood pressure for the last 3 weeks that they've been on this unit a systolic of 95? And most likely the primary RN will be the person who can give that information to the rest of the team. Also administering medications that are within your scope and that you feel comfortable with, IV fluid boluses, stat antibiotics, things like that, but making sure that you're not leaving the patient's bedside. You shouldn't be running around to get those medications, but rather calling out to have people run those things to you and staying by the patient's side.
I'm just going to add one other touch point. I'm sorry. So I always like to, one of the things, and like I said, in the years that I've been doing this, I am a very strong nurse advocate. I believe nursing does amazing work every single day. But whenever we look at sometimes with quality things, one of the things when I've gone to rapid responses, I'm like, oh, Amanda's the primary nurse. So what's going on with the patient? Why is the patient here? And the thing that made me cringe all the time, because it just made me feel like it broke my nursing soul, was, I don't know, I'm just covering. Right? So making sure you understand that if you're covering, at the end of the day, you're responsible for the patient. It doesn't mean that you have to go through the entire history, but know why the patient's here, know what's going on, and you should be advocating for that. And I know, I get it, like often it's just like, hey, I'm just gonna go take a quick break, but you should know what's happening with the people that you're watching. I think that that's super important.
Code cart manager. So this is typically a staff RN as well. But I also like to point out that a lot of times during rapid responses and code blues, we're lucky enough to also have some type of nursing leadership or supervisor director, because yes, it's important to have an idea about ACLS knowledge, but of course it's not realistic that every single person is certified in ACLS and comfortable knowing the medications, but working together to make sure that the ACLS protocol that's being run at the bedside is also being run at the code cart, setting up those meds, anticipating orders, also knowing what's available to you in the code cart. A lot of times in rapids, as the nurse, you're screaming out, hey, can I get a setup for supplies? Can I get a setup for IVs and setup for lab draws? That person has all access to that in the code cart and should hopefully be able to get that stuff ready and deliver it to the room. So again, a lot of communication for the code cart manager is the listening part of it. On this slide too, it talks about managing crowd control. Obviously in a perfect world and in the picture that we saw in the presentation earlier, the code cart's at the patient's bedside, but a lot of times with the space that we have, with the limitations, it's outside the room. And of course it can be hard with different consults and different teams coming to see the patient in the moment, trying your best to make sure that anybody who doesn't need to be in the room at the moment and maybe is just kind of standing around taking up space, getting in the way, is out of the way, getting a chair maybe for a family member to wait out in the hallway while we're addressing anything critical. I feel like that could be one of the most helpful roles actually.
Yeah, and it's okay to say, there's too many people in the room. It's okay to say, I can't hear what Amanda's saying. Can we please quiet down? Because at the end of the day, we're all trying to take care of the patient. And it would be a really good debrief point at the end to say, hey, these are some of the challenges that we've faced during this resuscitation.
RRT code team nurse is always going to be an ICU nurse with ACLS certification. So familiar with those algorithms and how to anticipate the orders. As the RRT nurse, I think the first thing we do when we walk in the room is just that doorway assessment, because we may arrive a few minutes after you've already started your resuscitation efforts, and we're just looking at, does this patient look like they're going to code in the next 2 minutes? And what can we do to prevent that? Addressing the ABCs. I definitely think one of the biggest things that we look at as soon as we walk in the room is IV access, assessing the IV access that they have, and most likely attempting to get at least a second IV placed, anticipating that we will be using it either for fluids or some type of crash cart medications if needed. Listening to the team leader and carrying out most of the interventions. As we said, the primary RN is there to give information to the team leader, so the rapid response nurse most of the time is actually carrying out the interventions that are ordered. We can draw labs, we can do ABGs, and once if the situation escalates to an actual code blue, we will be the ones in charge of titrating any vasoactive medications, sedation. We can assist with the intubation and airway management. The rapid response nurse always comes with 2 boxes. I'm not sure if anybody even knows what's in those boxes, but the blue box is our intubation and airway box, which has medications that we can use to assist anesthesia with intubating the patient. And then the IO kit is in our yellow box. So if there's a situation where we can't get access, we're able to pass that off to a provider to make sure that we have the equipment ready to put in an IO and have access stat if needed. So those are the things that we're coming prepared with every time. Hopefully the RRT nurse should be introducing themselves when they walk in the room. And again, that question of why is the rapid called is probably going to be the first thing that you hear. But use that person as your resource if you're not an ICU nurse. If you don't feel comfortable pushing a medication, something that you have never given before, for example, adenosine. Hey, what's the protocol for pushing adenosine? And it's completely acceptable to ask the ICU nurse to either run through the protocol with you or be the one pushing the medication if it's something you're not comfortable with. The recorder. Something that I like to say about the recorder is once that person is recording, that should be their only job. They should stand there with that binder and start the sheet until the sheet is filled out and finished. This person shouldn't be running around as the runner getting supplies. They are the key to all the communication that's going on in the room. Communicating with the team leader, making sure that every order that's stated by the team leader is being transcribed, but also being followed by the nurses and the rest of the team. Communicating at the end with the rapid response nurse to check over the sheet, make sure that every intervention that was done is accurately recorded. Keeping watch of the patient's vital signs, keeping track of the vital signs throughout the rapid, and of course, making suggestions as needed too, hopefully with a knowledge of some sort of ACLS protocol. But just communication is definitely the key for the recorder.
And the recorder is actually one of 3 of the most important people in the room. The first one is the patient. Second one is the team leader because they're guiding the entire resuscitation. And the third person is the recorder. Why? Because they are CYAing for everyone, making sure that everything's covered. I'm going to tell you, so when I was first starting my program and, I was the lone nurse practitioner at the time, in order to get buy-in so that I can get more nurse practitioners, I had said, can you go ahead and I had to identify things that I could help out with. And so one of the things I did was work on a lot on quality. And I hear that we have similar challenges to my previous institution in terms of accurate written records of what's going on. I'm going to tell you the Northwell code sheet, all code sheets, it's not Northwell code sheet because everywhere else I've worked, if you gave it to me right now and I've been in millions of resuscitations, I wouldn't be able to fill it out correctly. I'm going to tell you, grab a piece of paper. I don't care if it's a piece of toilet paper, tape, and you're going to write 10:01, Andrew Wong walked in the room. 10:02, 1 milligram of epi given. 10:03, CPR was started. Whatever it is, and then afterwards go and transcribe it to make sure it's accurate. Because at the end of the day, you're protecting everyone else in that room. Number one, because we want to make sure we have accurate documentation. But the other component of it is that when we look at this inequality, you have to paint that picture, right? Because often it'll be like, oh, I don't know, they were in like VFib and they gave a lot of epi, but they didn't give amio. Why didn't they give amio? Well, it was given, it was never documented, right? So making sure that that's important.
For our compressor, this is anybody with BLS certification. In the ICUs, a lot of times we utilize our strong PCAs, RNs, the secondary provider, but it's important that there's at least 2 people designated because as we spoke about before, compressions are exhausting and the compressor should be able to vocalize when they're ready to switch out, when they're feeling tired. We don't want the compressor tiring out to affect the patient's outcome. So that's the most important thing, is just being vocal about, okay, time to switch. So assigning 2 people to that role to switch in and out. If you're the person waiting to go, make sure you're vocalizing, hey, I'm here behind you. I'm ready when you're ready to switch. Keeping an open ear for any orders that may indicate restarting compressions or stopping compressions, pulse checks and things like that. And then of course, knowing to keep our rate 100 to 120 beats per minute, our 2 inches of depth and our chest recoil. I think the Zoll is the best tool that we have for this. Listen out for that Zoll because not only will it tell you if you need to fix something with your compressions, but it'll also give you the reinforcement if you're doing great with your compressions, keep up the rate, keep up the depth, it will give you that feedback. And then working together with your airway manager is important here because sometimes I think in the chaos of resuscitation, we can forget our basic BLS of 30 compressions to 2 breaths. So making sure you're counting out those compressions if your patient doesn't have an advanced airway, making sure you're communicating with the airway manager, which is a lot of times your respiratory therapist or anesthesia, that you're keeping that ratio correct. And then once the patient has the advanced airway placed, 1 ventilation every 6 seconds. And speaking of the airway manager, respiratory therapy will respond to every single rapid response, even if it's not something having to do with respiratory. They can do any respiratory intervention, suctioning, setting up oxygen, nebulizers, set up a high flow, set up a BiPAP, and they will be the one managing the airway until it's deemed that the patient's not able to protect their airway. If that's the case, you'll hear the anesthesia sat overhead. Anesthesia will be called as decided by the team leader, and they can assist anesthesia, who becomes the airway manager, with the intubation. Once patient is intubated, the anesthesiologist usually will leave and the respiratory therapist will reassume that airway manager role. So just being aware of who is that person in the blue scrubs, why are they here, and what can they do for me, how can they help me? They're always going to be there, no matter what the situation.
So knowing what's in the toolbox is important. So these are just some examples of different things. So, you know, one thing I always like to tell people, and I see a code card in here, is you should know where things are in the code card. I don't know this code card, but I can tell you my previous institutions, I was able to tell you that the airway equipment was in the 3rd drawer, the laryngoscope was on the right-hand side, the non-rebreather was on the left-hand side. And being able to speak to that at that level, especially in an emergency situation, is really great, because if you have a lot of extra helping hands and you can't go ahead and reach for something, can you go ahead and get the nasopharyngeal airway, which is in the left-hand side of the third drawer. Some of the devices here that you'll see is different blades, so Macintosh and Miller blades, which are utilized to help facilitate intubation. There may be other devices that you may see. LMAs are something that's a really great backup device. Really, you just shove it in. It's a blind intubation. They utilize this in the OR space a lot. That's why patients come out of the OR and they're like, oh, I feel like I had a frog in my throat. Well, you had an LMA, which is a big balloon in the back of your throat. Really great way to secure an airway if you don't need it for a very long time. Why do we not use it for everyone? Because it causes pressure, and you can have pressure injuries in the back of your airway as well. Nasal pharyngeal airways are really great things to go ahead for patients who have that snoring or really just, are somnolent. Oral pharyngeal airway, you guys have probably seen this in your basic life support. It really helps. The largest airway obstructor is your tongue, and so what it does is just displaces your airway that way.
When we're talking about outside the room, I kind of touched upon the code cart manager doing that crowd control. Other important roles, if as needed, of course, I think the best way to communicate is from going into the room to that code cart manager, that person who's kind of manning outside of the room, to passing on to anybody else who's available to help out. Like Andrew said before, you don't want to have the entire unit in the room because we need to take care of the other patients, but hopefully there will be a few other people around, of course, PCAs, running for things like dropping off stat labs that we want to get results from right away. Picking up medications from pharmacy that may not be in our Pyxis, making phone calls to make sure that medications get verified, or calling if there's a team that's unaware that their patient's decompensating and needs to be notified. If there's an MTP or blood transfusion needs to be given, the ability to run down to the blood bank and pick it. People are faster than the tube system. So pick up that blood, pick up the meds, run down the labs. It will end up causing much less delay for the patient.
And like I said, one of the things that's really important is always finding what you can do to help, right? Everyone wants to help. If I told you someone went into cardiac arrest here right now, all of you guys would want to help. But figuring out how you can help is really important. One thing is also family presence is something that, can happen, but it is also in the literature that should happen. It allows the family to fully understand, especially for patients who have a lot of chronic issues, who, may have been slowly decompensating, for them to be there, but being able to support them through it, because the biggest thing that leads to anxiety is not knowing. Why are they compressing on my family member's chest? What is happening? What is the next step? And, I saw this on one of the units I was rounding, and all of a sudden there was a code blue, and the wife was at the bedside, and they were all busy doing stuff, and I just literally went and talked to her, and I said, and little things like, oh, how long have you guys been together? I'm really sorry this is going through right now. It just helped to distract her, and then being able to say, okay, it sounds like they just regained a pulse, which, we don't know what else is going on, but the next steps are we're going to probably move into the intensive care unit. I want you to understand, I'm going to go back into the room and check on, see what's going on, and building that rapport is really important. Really quickly about access. So there's all different types of access. As you guys know, IV access, central line access, IO access. If I were to ask you, someone who is bleeding out, and you had a central line versus a peripheral IV, which one's better? I heard central line, and I heard peripheral. Central line, you can use it if you need it, but peripheral is actually the answer. You need something short and fat. There's something called Posture's law. You can look that up. When we want to give large amounts of volume, it's better. A GI bleeder should have, 5 different 14 gauge IVs. You can dump fluid in much quicker. That's the difference between the cordis and the central line. IOs are really quick, down and dirty access. You can get it in. It's good for 24 to 48 hours. And so we can give volume and then thinking about access later. The reason why I tell you about this is that if you are noticing where your teams are going ahead and they're trying to get the central line, or they're trying to intubate a patient who's in the middle of a cardiac arrest, we can put an IO in, so we can give the things, and we don't have to worry about someone getting stuck or anything like that, or we're intubating and we're not doing our
this Pearsall in signed a 382. She was our
so I
patient.
talk really quickly. This is kind of all of the different things. So 18 gauge, 16 gauge, all of this can give large amounts of volume in that way.
4450, Paul? Okay.
When we are talking about being familiar with what's in your toolbox too, I think if you ever have the chance and there's an open code card on the unit and you're not familiar with it, I mean, we have one today. I'm assuming we're going to go through it, but if not, just rifle through, get familiar to what your different draws are. Where's my IV access located? Where's my lab draw equipment? Where do we keep the fluids? What are the different medications we have in our tray? And I know there's an iLearn that I was told to talk about too, a new iLearn about code cart medications coming out. But in terms of ACLS protocol, a lot of the frequent medications that we're giving are epinephrine, our bicarb, our dextrose, our calcium chloride you're going to see in Bristojet. And if you're not familiar, we're just going to go through how to connect and how to use the Bristojet. So they come in these like cardboard boxes labeled pretty big with which medication is being used. The nice thing about these is that you can set them up and have them ready to go without drawing anything up in an emergent situation and have it ready. If you know that, if you can see that this code is going on and you know the 3 minutes are coming close, we're going to need another epi. If you're anticipating that and you can set it up and have it ready to go, again, it keeps from delaying anything to get to the patient.
These are all universal nationwide. I'll tell you, back in the day when I used to do EMS, it was like, oh, if their blood sugar's low, you give them the blue box. If their heart rate's low, give them the purple box. If you don't have a pulse, give them the brown box.
When you open up these boxes, there's a tab on the side that says open. You're supposed to open from one specific side. This is what should come out is 2 pieces, one with the medication side and one with your side that you'll connect to your IV access. So the first step is taking apart these 2 pieces. You'll find they both have a yellow cap, flicking off those yellow caps and twisting the medication together, and then you're set to go. That green piece is your lure lock that will connect right up to the patient's access. You don't have to prime the medication. You don't have to draw anything up. You connect and it can push. So it's important to know, especially if you're the code cart manager, that's your assigned role and you've never done it before, how to set up those medications and get them prepped and ready to hand into the room. And you want to make those green needles can screw off, but you want to make sure that those stay on before pushing medication into the IV.
Most of you are young, so you probably don't remember back in the day there were rubber stoppers that you would actually stick it into the rubber stopper to deliver the drug. Obviously scrubbing the hub before you did that. So one of the things about resuscitation, I want to ask the question to you guys, do you think CPR saves patients' lives? Directly. Well, I asked the question, so of course not, right? But it saves lives indirectly, right? Because what we're doing is when someone's heart stops, what we're doing is we're replacing the function of the heart by doing chest compressions, right? 30 compressions, 2 ventilations, allowing for full chest recoil. But one of the other big things is for everyone to be thinking about what is the underlying cause. So I talked earlier about this, and we're going to just go through this. In ACLS, we call this H's and T's, but I always think it's really important for everyone to understand this, especially, nurses, because we learned about all of these things. So hypovolemia, what's the story typically that you'll hear for someone with hypovolemia? Good, low blood pressure. Okay. I heard somebody say something on Teams. All right, they may go ahead and have some tachycardia, but more so the story would be that I've been having nausea, vomiting, diarrhea for the last couple of days, and now I'm in cardiac arrest. I just delivered a baby, and I started bleeding out, and now I'm in cardiac arrest, right? Those are the things. I got shot in my femoral artery, and it was spewing blood everywhere, and now I'm in cardiac arrest. A post-trauma patient, blood all over the floor, cardiac arrest, right? So how do I fix hypovolemia? Good, give them volume, right? So I always say fluid, but you don't want to make the patient bleed clear. Typically, we will anticipate that we'd be giving them volume. If they are bleeding, we want to make sure that we're giving them blood. Great, how about hypoxia or hypoxemia? What's that story look like? Someone who's in cardiac arrest because of hypoxemia. Good, maybe they're having some trouble breathing, maybe they came in for COVID, they have a pneumonia right before this, they were looking blue, their pulse ox was low, they weren't really saturating well, all of those things. How do we fix hypoxemia? Is we go ahead and we give them oxygen, right? So if they're in cardiac arrest, I always like to tell people, you don't need to intubate anyone in cardiac arrest, unless they are in cardiac arrest because of hypoxemia or hypoxia, or they don't have an airway, meaning that you're not able to ventilate the patient appropriately. So always thinking about that is really important. We need to give high flow 100% oxygen through ET tube or anything like that. Hydrogen ion acidosis. Tell me about that. Acidosis, right? So there's 2 different types of acidosis that you guys probably, everyone in this room should know back from nursing school. Metabolic and respiratory, right? How do I fix respiratory acidosis? What's the picture? What's the story that I hear? It could be a picture of a heavy-set obese person who who took their BiPAP off overnight or took their CPAP off overnight, and now they have hypercapnia or anything like that, and that's causing a respiratory acidosis. How do I fix that? Blow off the CO2, right? Because that's why if someone's having trouble breathing, they're trying to blow off CO2 sometimes, right? So thinking about that, intubating that patient and blowing off that CO2. How about metabolic acidosis? What's that story? Typically, you'll see that in like patients with severe metabolic acidosis who may be like uremic, or maybe you'll see that in like someone with severe DKA, those different types of things. Again, to fix that, fix the underlying cause. However, there is some literature out there that doesn't support this anymore, but you can go ahead and give some sodium bicarb, because sodium bicarb is basically baking soda, right? So if I have a lot of acid, I give them a little base. It only fixes your problem for a few minutes. My ICU people will tell you that. Hypoglycemia, we talked about, that's simple, give them sugar. Hypo and hyperkalemia. What are some of the things that you might hear? This is actually a board question if you were ever to get certified, how would I tell someone may have hyperkalemia? EKG changes, you might have an elevated T wave, right? So remembering your heart works on a lot of sodium and potassium channels, and so a lot of the electrolytes can affect that. Hyperkalemia is easier to fix. They need dialysis, but they need to have a pulse to go to dialysis. I'm assuming you guys are from dialysis, right? Just of your dress, but they need to have a pulse to have to go to dialysis. How would I fix that in the middle of a cardiac arrest? We can do some shifts, right? So maybe I go ahead and give them some dextrose and insulin. There's a lot of literature out there that says always give the dextrose first, sugar them up before you give them the insulin. The idea from that, I'll bring you back to nursing school. Remember, with potassium, I always like to say, the potassium is like the t-shirts that are my clothes that are scattered around my room. Mom and dad are coming over, so guess what? I'm gonna shove it all in my closet, right? I'm using insulin to push it into the cell, but those clothes are still there. So until I do laundry, which is my dialysis, those are the things. So we can go ahead and shift them. We can also give them sodium bicarb. We can give them things like albuterol, all of those things to shift that. Hypokalemia is actually much harder to fix. However, we work in a center that you can actually fix that here. Why? Back in the day, we didn't have this technology. Now we can put patients on this therapy. And we can also bring them up to the helipad, walk them around the CTU. ECMO, right? ECMO is a game changer now because we can give extracorporeal membrane oxygenation because I can't push potassium in a patient. The only time that you would be pushing potassium in a patient is if you were working on death row, because that's how we go ahead and give someone the death sentence. Because what it does is it basically floods all of those channels and it makes the heart go to standstill. Hypothermia, I always like to say, they're not dead until they're cold and dead. I'll tell you the story. When I worked at University of Rochester Medical Center, there was a 98-year-old female who came in from EMS and they were starting CPR en route. And when she showed up, I was like, she is freezing. And I remember I worked in Rochester, New York. I don't know how long this lady was dead. She probably never should have been resuscitated. But because after we were doing the chest compressions and they're bagging her, she looked like she had bilateral breast implants because she had bilateral pneumothoraxes that were actually causing all of this. But at the end of the day, your heart actually has a diving reflex when you go ahead and get cold. And so I basically said to the doctor, I'll write whatever you want me to write down. This is just torture. But at the end of the day, you're not dead until you're warm and dead. Tension pneumothorax. What's the difference between a tension pneumothorax and a pneumothorax? Tension, right? So really quickly, signs and symptoms of that might be a patient who is all of a sudden complaining of shortness of breath. Maybe they're tall and lanky. The other concerns that you might see in your cardiac surgery patients, right? Maybe they already had a pneumothorax and it's getting larger and expanding in space. So signs and symptoms of a tension pneumothorax are patients who are in cardiac arrest. You may have some tracheal deviation, only unilateral chest rise. What that patient ultimately needs is a needle chest decompression and then a chest tube. Cardiac tamponade, you see this in your patients with post-cardiac surgery. Cancer patients are also at risk for that. Remember back in your school when you learned about Beck's triad, right? Muffled heart sounds, hypotension, all of the bradycardia. And so all of those good things, the treatment for that is a pericardial window or a pericardial centesis. Toxins, what's the story for toxins? What toxins do we give in the hospital? Huh? Opioids, I love it. Excellent. So opioids, what would I go ahead and do to reverse opioids? So I gave someone morphine, Dilaudid, right? Naloxone or Narcan, okay? Typical doses are anywhere from 0.4 to 2 milligrams. Back in the day when I did EMS, the New York City EMS protocol was to give 2 milligrams. And they said if you were a smart medic, you gave them enough till they started breathing and pushed the rest in the ambulance bay in the ER because that person's gonna be pissed off you took away their high. But knowing what the patient got beforehand is really important. How about the other toxin? How about your midazolam, Ativan, lorazepam, benzodiazepines, right? Does anyone know the reversal agent for benzos? Flumazenil or romazicon. I see some people shaking their head yes, right? So Ben has the flu, as one of my fellows made that up, right? So benzodiazepines, flumazenil. And so you can give those things if you think about specific toxins. Speaking about toxins, one other thing that can be a toxin that is being treated all over Northwell. The reason why you guys have an iLearn on the new hybrid medication tray is there's a few medications that are being added and taken away from the first medication tray. Intralipid or lipids are actually being added to it, and that's used to treat lidocaine toxicity. So if anyone has had lidocaine, bupivacaine, all of those different canes, it can be treated through lidocaine, through lipids. Pulmonary thrombosis, what's that story? Anyone who's in the hospital. That's why you give those heparin and the Lovenox shots. That's why you put SCDs on. That's why you get them up and walking, right? So pulmonary thrombosis is typically, I always like to tell people, if you're trying to think of a clinical reason, everyone in the hospital is at risk. But in my pre-hospital days, it's the patient that I intubated who is still blue while I'm doing chest compressions on them. Why? Because there is a VP shunt, right? And they're not a VP shunt, but there is a shunt and they're not actually perfusing, even though I'm giving them high flow oxygen. And how do we fix a pulmonary thrombosis? Does anyone know? Give them some type of clot buster, right? So back in the day, we gave TPA, you can give tenecteplase, all of those good things. And then coronary thrombosis is one of the harder things. That's typically a heart attack. And like I said, they can't go to dialysis without a pulse. They cannot go to the cath lab without a pulse, unless you can put them on ECMO. We talked about this really quickly. I'm not going to go through this really quickly. You guys should know that there are drugs that are going to be, and we're still working on, the system wants to have the intubation kits that you were talking about for rapid sequence intubation. They want it throughout the hospital in different areas. So they're most likely are going to go into the PICSISs. So just know that it's going to be available. More to come with that. Placement and proof, we talked a little bit earlier about if you intubate this patient and this patient gets intubated, know your zoles. Your zoles have the ability to do something called end-tidal CO2. End-tidal CO2 measures the amount of exhaled CO2. Remember the difference between ventilation and oxygenation, right? Ventilation is me breathing in oxygen, breathing out CO2. I measure that through end-tidal CO2. If I go ahead and talk about oxygenation, oxygenation is me breathing in oxygen, it going down my lungs, through my trachea, through the alveolar, connects to the red blood cell, and I can measure that with a pulse ox, right? I'm not going to go through this just because of time. You want to go stroke?
Yeah. I'm not going to talk about so much about the patho of the code stroke, but I think what's important to remember, anytime a patient is displaying any type of altered mental status, a new neurological deficit, we're always going to call a rapid response first. And kind of how I touched upon before, that secondary provider will often come in the room and start working on that neurological assessment stat to determine, do we need to call a code stroke on this patient? And what's the process of that? If it's determined that there is suspicion for some type of stroke based on the initial assessment, once the rapid team gets into the room, that code stroke is called overhead, and then you'll have your neurology team as well as a neurology nurse that comes into the room, completes a checklist, will order what labs need to be ordered, and order the scans that need to be ordered for a code stroke. The scan that will be ordered is a CT head non-contrast. These other scans are things that can help us later on in the process, but the CT head non-con is what will be ordered immediately, just to rule out, to make sure that there's no bleed. And then usually the code stroke will end at that point. The patient will be dispoed, and we can give tenecteplase. We can treat if we think that there's some type of ischemic stroke, but what's important to know for us as the nurses is call that rapid response, know the last known normal, know the baseline, so you can communicate that to the team and we can get the code stroke running.
Go through MTP, really?
And then same with MTP. We know when we call an MTP, you're going to get that big cooler. That's going to have your PRBCs, platelets, plasma. If you do get to the point where there's an MTP where we need a rapid transfuser, what's important to know, there's one located in MICU in 5 Tower and one located in SICU in 8 Tower. That's where your Belmont rapid transfusers are going to be. That would be up to the responsibility of the ICU nurse to set that up and run that, but you definitely need to have somebody running to pick up the blood. All that blood still needs to be identified using the same protocol that we use to identify blood when it's not an emergent situation. And then also having lots of normal saline, that's what we're going to use to resuscitate the patient in the meantime. What's important is your large bore IVs, like Andrew was saying before, ideally a 20 gauge or an 18 gauge IV, but we can also use a centrally placed cordis, which is an introducer, a large bore central line to run the blood, preferably over even like an IO or a central line.
Great. And the last thing I really want to just touch on is really considering if your patient's stable or moving. I always like to tell people whenever I have my floor nurses, they're like, get this patient off my unit. This is not what I'm here to do. But remembering that we want to make sure we're transporting the patient in a safe manner. So anticipating, advocating that if this patient needs to be upgraded, that's one thing to also anticipate what the next 48 hours is going to look like. What are the worst case scenarios? Be comprehensive. Always anticipate, don't be afraid to call a rapid response. That's one of the other things. I don't have any physicians in the room, right? But I've heard a lot of different things. I mean, it's on both ends, right? Because I've been to rapid responses like this didn't need to be a rapid response, but I would much rather the person who knows the patient best and is noticing these subtle changes call for help than to say, maybe it'll be better, or Andrew said it was going to be okay, so it's going to be okay, right? So no, always advocating for your patients. The one thing to think about it when you are transporting patients, this is something that I put together in one of the last ICUs I worked in, thinking about your patient's neurologic status. So like you were talking about your stroke codes, before they go into stroke, if they're not protecting their airway, protect that airway. I don't care if they need to get a CAT scan, they're going to aspirate on themselves. Oxygen delivery, ambu bag, this is all preparatory things, right? So you wouldn't care for a seizure patient without having suction ready at the bedside because they could have a seizure and you would have to manage that. So thinking about those things and thinking critically is what's really important. So again, take a breath. This is what you're made for and this is what we do.